Hello, my name is Dr. Steve Ommen. I'm the medical director for the Center for Connected Care and a clinical cardiologist at the Mayo Clinic in Rochester, Minnesota. And it's my pleasure to be able to speak to you all today about the evolving telehealth strategies that we've seen in the face of the COVID-19 public health emergency. So this is a brief outline of what we're going to touch during my comments, and then hopefully we'll have time later on for questions and answers with the other panelists. So just to give you some background, Mayo Clinic started in the upper Midwest of the United States in a small town in Rochester, Minnesota, after a tornado devastated the community here, and the local nuns recruited Dr. Mayo to help build a hospital here to take care of the wounded. It has now evolved to a large global institution. We have our primary destination medical campus still in Minnesota, and you can see the statistics on the number of physicians and patients we see there annually. We also have small community-based practices in the 3 surrounding states to serve over 500,000 patients a year for their primary care needs. We have other destination medical campuses in Phoenix, Arizona, and Jacksonville, Florida, to meet the needs across the nation of the United States and across the world for patients who need the level of expertise that Mayo Clinic provides. About 6 or 7 years ago, Mayo Clinic leadership saw that there was going to be a need to transition healthcare from the traditional on-site, in-person evaluations that we're all used to doing, recognizing that people were going to want to take advantage of digital tools, digital communications to get their healthcare more easily. And it was from this vision that they established the Center for Connected Care at Mayo Clinic. And just to give you a background of what we do, we have several products and services that are designed to connect Mayo Clinic to our patients around the world. The first is we're in charge of the user interface for our patient portal. We don't just use the electronic health record portal. We have some specific things that we do that we know our patients have asked for. So we control the user experience both on computers and on mobile application for our patients. We're also the team that does all of the video telemedicine activities for Mayo Clinic. So that can be everything from acute care telemedicine activities like telestroke, teleneonatology, teleemergency medicine for acute facility-to-facility care. We also do video visits to patients in their homes or offices or school when they need care, and they don't need to be in our offices for specific reasons. And we'll talk a lot more in detail about how that's changed over the time since March. Finally, we also are the team that's in charge of what we call remote patient monitoring, which is the ability to gather patient-generated data, either through questions and answers, surveys, or remote sensors that are monitoring physiologic data about our patients that are automatically uploaded to our electronic environment. So our centralized team of nurses can react to that data and escalate a patient's care if necessary. So we have been building this business plan for a number of years and had a roadmap for clinical adoption in each clinical specialty at Mayo Clinic over the next 3 to 5 years. And these are just an infographic showing some of our activities at the end of last year. So we certainly had a lot of activity going on at that time, but you're going to see in the upcoming slides, as happens for many of you, the utilization of these tools dramatically increased with COVID-19. Just a brief comment on how we're organized. We're organized on the left around the products, so the video services or the remote patient monitoring services or the portal services. But then we have a whole operational team that's built into our clinic. So we also have the lawyers and compliance officers to make sure that we're doing the right things. We have business specialists who understand whether it makes sense to do a clinical service by telemedicine, and obviously all the technical support that we need to handle that. So what changed for us at Mayo Clinic? Well, when the COVID-19 public health emergency came up, we were confident that we had a tool set that the institution could utilize to care for our patients. And these are kind of the 4 main categories that we look to solve problems. How do we help people when they think they might have a diagnosis in the pre-diagnostic phase? How do we help take care of patients in the hospital better, preserving isolation and personal protective equipment? How do we get people out of the hospital sooner, but still safely monitored at home? And you can see on the bottom there that we actually increased the utilization of our services by more than 10,000% within 3 weeks, which meant our 3 to 5 year roadmap was blown out of the water. And we had to get to we had to provide self-help guides for the individual clinics and departments to get going on their own so that they could keep their practices floating. Some of the tools that we developed in real time was we stood up a COVID helpline for our patients and employees that they could call in and talk to nurses and determine whether or not they might need COVID testing, whether they should isolate, whether their family members should be tested. And you can see here the volumes increased tremendously. And then as the wave kind of came into Minnesota in June, you can see that's where the uptick and the peak of phone calls happened. You can see good statistics on how quickly we got to calls and how few people had to abandon that line. We also developed an online tool to do the same thing, where patients answered a series of questions and then were given advice about whether they should report to a testing facility, or whether they needed to talk to their primary care provider, or whether they could simply self-care at home. And this was a tool that changed probably on a weekly or even more frequent basis than that, as our infection control team learned more about the predictors of who was going to be COVID positive and COVID negative. And so again, these are daily volumes that you're seeing of utilization of that tool. Each of those spikes is obviously the weekends. People weren't utilizing the tool as much on the weekends. We also stood up a new service in something we call Express Care Online. This is a service that we already have that handles the 20 most common primary care diagnoses. Again, it's a completely online experience for our existing patients that if they are having symptoms of something, say like a urinary tract infection, they can answer a few questions online, and within an hour, one of our nurse practitioners will respond to the questions and answers, and if appropriate, prescribe an antibiotic according to algorithms that we have developed that we ensure safety and that patients get treated appropriately. We stood up a new module to add to those 20 to specifically treat patients who have COVID-19 symptoms. And again, this is the graph that shows the utilization of that over the period of March through the end of July. In the hospital, when we had patients coming in and we were trying to make sure that we were keeping patients whose COVID status was unknown or who were confirmed to be COVID positive isolated from other patients and from our employees who didn't have to be in their rooms, we reimagined the use of our telemedicine equipment we have in the hospital and started to use it within our hospital so that we could do virtual consults in the hospital, virtual nurse check-ins with the patients in the hospital, again, to keep the isolation present so that patients could be safe and we could keep our personal protective equipment reserves intact. We also deployed new equipment to a bunch of our smaller rural hospitals, our main campus hospitals, and to nearly 100 skilled nursing facilities in our region. Again, with the purpose of being able to do virtual evaluations of patients rather than forcing them to come into a medical center for an evaluation at any time. This is the graph that summarizes the use of those in-facility video equipment. The blue line at the top is the emergency department and inpatient video isolation camera usage. That was obviously the bigger utilization. The skilled nursing facility is the red line kind of near the bottom. But if you look at that, that's nearly 500 visits a week that were being handled. Those patients otherwise would have come into the emergency department or to their primary care office for evaluation, or a provider would have gone to the nursing facility. But here we were able to preserve isolation for those individuals and determine whether their care needed to be escalated or not. We also made available on-demand video consults. This is part of that video isolation activity. So for patients who were in the hospital, if they suddenly started having arrhythmias, for instance, rather than have a cardiologist walk to that patient's room and do a history and physical examination, they could do it all by video first and determine whether they needed to go to the room or not, or whether they could give advice about care remotely. Again, saving interactions, saving contacts, saving exposures for our patients and our providers. Similar to many of you, the rules around patients in the hospital were such that for a while there were no non-admitted patients available. So no family members, no friends could come visit the patients in the hospital. For many people, this isn't a problem because they have their smartphones or their tablets and they're able to communicate with their family and friends easily. But there are patients who don't have those tools available to them. And we actually deployed some tablets we have at Mayo Clinic to the rooms of those patients who didn't have those services to allow them to connect to their friends and family on the outside. This is purely a service for the patients and families to help reduce their social isolation from their family and friends. We also deployed inpatient e-consultations. So this is simply a record review of the patient by another specialist who then documents a formal recommendation for either further testing or further consultations as necessary. This was very low volume prior to COVID-19 in the inpatient practice. It's used widely in the outpatient practice, but you can see that between March and September, we did thousands of inpatient e-consultations, again, with the goal of speeding time to important consultation decisions and preserving isolation for those individuals. I mentioned the skilled nursing facilities that we deploy the technologies to. This again is a blow-up view of the number of volumes by week of skilled nursing facility appointments that were undertaken by our primary care doctors taking care for these patients that otherwise would have ended up in a facility or at least in an in-person evaluation with individuals of the care team. We'll shift now to the primary outpatient practice. As you can imagine, like most hospital systems in the US, there was a while where we shut down elective outpatient evaluations, and that was on about March 11th. And then you can see here, both phone appointments and video appointments started to increase. There was a rapid rise in phone appointments because that was super easy for people to do that required no additional equipment in their offices. But gradually, video appointments have become more prevalent. These data end at the 1st of September. And as we get in through October, we're starting to see the video appointments pick up even more. But these were replacing the in-person face-to-face visits with video appointments for people. Our patients like it. This is patient satisfaction scores regarding their visit type. And the metric we're looking at here is the likelihood that that patient would recommend this visit type to other friends and families if it was appropriate for their care. And you can see that basically all the phone and video are equivalent to, or in the case of video, 1 point higher than what patients were recommending for in-person visits. So this patient satisfaction did not suffer, even though we were ramping up really rapidly. And as you can imagine, had some technical challenges that we had to overcome. They still thought this was a great way to do their healthcare. And they were happy and grateful that they could get their care without having to be exposed. Remote patient monitoring is the last product line we have in the Center for Connected Care. Again, this is using devices and data collection tools in the patient's home so we can make sure they're doing okay. So we have one pathway that was for complex patients who were positive for COVID-19. We had this same pathway prior to COVID, and we're monitoring about 300 to 500 patients per day who had high risk for readmissions. But we redeployed a specific set of tools to monitor COVID-19 positive patients. This included giving them a cellular-enabled tablet with a blood pressure monitor, pulse ox, weight scale, thermometer, and then twice daily check-ins from our nursing team to determine whether they were doing okay, or if their oxygen stats were dropping, do they need to have an EMS evaluation or possibly come into the emergency department. We also developed a more facilitated self-help interactive care plan for lower acuity patients. So this would be patients who didn't have major comorbidities, happened to be COVID positive, but didn't have major symptoms. And we had a algorithmic, again, twice daily check-in with those patients of how they were doing, monitored less intensely by the nurses, but these were lower acuity patients. And this is the utilization of that remote patient monitoring, again, starting at the beginning of March on the far left through the beginning of September on the right. In the red is the complicated COVID patients, so the complex care here. And you can see that we were up to 500 patients a day just of that subtype. We had an additional, in the green, 250, 300 patients on the interactive care plan. And that is on top of the baseline of the 250 to 300 patients who didn't have COVID, but also need a remote monitoring capability. So overall, we were monitoring about 1,000 patients per day in their homes through July. And the patient satisfaction on this is also extremely high. We did detect patients whose oxygen saturations required us to mobilize emergency response systems to go to the patient's homes. In many cases, those patients were stabilized in their homes and never had to come to the hospital. And we have emerging data that suggests that amongst the patients on this remote patient monitoring team who did end up needing hospitalization as a result of their monitors in their homes, their hospital course had a lower acuity score, shorter time to discharge. So we really do feel that this intervention allowed patients to get intervention in a way that kept them less sick than they would have been otherwise. And this is an example of the patient satisfaction from the remote monitoring program, where 90+% of patients would be likely or extremely likely to recommend this program if the need arose. And then we've got all kinds of personal comments, as here on the right-hand side of the screen, about how well patients felt that they were being watched by their trusted care team. This is the summation of all of the digital connections that we launched during that time period. You can see in early March, we were interacting digitally with about 500 patients per day. That peaked to nearly 8,000 patients per day at one point in April. And then Mayo Clinic reactivated our clinical practice to get people back here to do on-site visits because we were doing so well controlling the infection in late April, early June. And that's where you start to see this tail off and then have this long plateau. We are now building, because we expect that this digital healthcare delivery will continue to grow as patients and providers have gotten to experience the benefits of doing care this way. Again, this is a rehash of the patient satisfaction for those visit types, all very strong and consistent with in-person visits. So what happened during COVID that allowed this to happen this way? Again, connected care existed at Mayo Clinic. We had built solid tools for utilization, but there were some limitations, particularly in the United States, to the adoption of these tool sets. On the provider side, on the healthcare system side, there was lack of adoption by clinical departments for a couple of reasons. One is habit. We were used to delivering care the same way for the last 150, 160 years and doing it really well. And providers didn't want to change that successful model. The other thing is the novel care delivery models. There's a tendency to try to add them on to the existing services. Well, to a physician, that just feels like extra work then. And so that's an impediment. And so you need to make sure that you incentivize or don't penalize people for trying new technologies. Another bottleneck to adoption was on the patient side. In the United States, we are regulated, our license is granted on a state-by-state basis. And typically, if we're going to do a direct patient to provider interaction, the provider needs to be licensed in the state where the patient exists at the time of that interaction. That's a major barrier to delivering digital healthcare. Reimbursement for the service provided is also limited by both the government and commercial payers we have through these narrow networks. So there was unnecessary bottlenecks on both the supply side and the demand side for delivering our connected care tools. With the public health emergency, on the patient side, the federal government and the commercial payers wiped away all their barriers. They said patients should get care digitally if that's the best way to deliver care. Licensure doesn't matter during this emergency. We'll reimburse the same as we will for face-to-face visits. So that totally eliminated the need for licensure and reimbursement considerations. So the only remaining bottleneck was patients not sure whether their care team, their hospital system provided telemedicine activities or not. On the provider side, similarly, the fact that we could do this and they were discouraged from seeing face-to-face totally opened up that bottleneck. The only major barrier that remained for us was getting the clinical departments onboarded to the digital tools, particularly the video tool sets, and the fact that we then reactivated our face-to-face practice before competencies were built up sufficiently. But that we really opened up a free-flowing pathway to utilize these services. And it's my belief that now that we've had a taste of this, particularly on the patient side, that they're going to demand that they get care this way when it's appropriate to get care that way. They're going to want convenient care, just like they want convenient banking and convenient travel arrangements that they can do from the palm of their hand or from the comfort of their home. If it's the appropriate way to get care, they're going to want us to provide that. And I think we're going to need to continue to do that around the world. So in summary, Mayo Clinic had the vision years ago, as many other provider organizations did, that telemedicine and digital healthcare delivery was the wave of the future. And we were able to take our existing tool services, rapidly deploy those to areas that were still on our roadmap for adoption, and also develop some new tool sets to empower patients to assess themselves and care for themselves during this pandemic. So I thank you very much for the opportunity to speak to you today and look forward to our interactions in the future.